Dear colleagues, the previous excellent session prepared for us the floor to discuss a relevant topic about controversy that faces tobacco harm reduction. All we know that harm reduction is one of the instruments and one of the main pillar of public health strategies. So we have now to hear and to see a presentation from tobacco harm reduction, a pillar of public health facing controversies. Dr. Kuna, the floor is yours.
Thank you. Good afternoon. I was just listening to the excellent session and discussion, and I think all panelists have raised very important questions about harm reduction and public awareness and public acceptance of this method. I think this is a pillar of public health facing controversies. I'm a practicing physician, and in my practice for the last 5 years, I'm using this in patients who are not able to quit smoking, and I can tell you that this is fantastic benefits for these patients. So it's a very useful method. The problem is how we can go into the mind of the policymakers and politicians. I can divide people into 3 groups. One group are bystanders, they are not interested in anything. The second one is open-minded and accept the new approach to fight the epidemic of tobacco smoking. And the third is just very conservative, and it's extremely difficult to change their position. Of course, I understand that any research sponsored by tobacco company is very controversial. But also by the many pharma company research is also controversial. This is not just the problem of the tobacco companies. So they have to find a way to communicate with the public. We know that the governments are very reluctant to implement tobacco harm reduction strategy into the public health policies. This is in many countries. But also the policy of WHO is that one, that they don't accept this one, as well as many societies, scientific societies. This is the reason that smoking is the single major factor in many diseases which can be effectively prevented. However, we know that COPD, lung cancer is very common in smokers, but also we all want to live healthy and long life. And if we look into so-called blue zones, one is in Greece, the Ikaria island, the second is Sardinia. And this is interesting observation that in Sardinia, 48% of male smokes, 48%. At the same time, in Europe, this is the place where men can expect the longest lifespan. So this is not just the smoking which is killing us, but also many other factors. And indeed, there is interaction between cigarette smoking and fine particulate matter in the risk of lung cancer and some other diseases, including coronary artery diseases. So we have to consider every factor: food, environment, tobacco smoke, stress, and also the level of the medical health. These are some risk factors. This is the table from the European Union, and we can see that airborne particles are as dangerous as active and passive smoking, and little less high plasma glucose. Of course, the modern anti-smoking policy is based on prevention, on some incentives gifts for tobacco use, and tobacco harm reduction policy. So this is for the cigarette smokers who are not yet ready to quit. But if they switch to one of the lower risk alternative products, we can expect that this brings some health benefits. The 7 FDA-approved medication in double long-term studies, as compared to the placebo is the light blue active drug is the dark blue. We see that the difference is usually below 10%, between 7 to 8%. And one of my favorite publications, which was published in Annals of Internal Medicine 17 years ago, described a population of COPD patients with active intervention for almost 15 years. So for 15 years was used just the doctor's advice, approved by FDA medication, and during these 15 years, only 22% of patients quit smoking. So 80% still smoke. So what can we do with this 80% of patients who are not able to quit smoking despite treatment according to the current recommendation of WHO and many other organizations? One positive information from the study is that even the patient, so-called intermittent quitter, which quit smoking for a while and return, or they smoke just a lower number of cigarettes, have some benefits. Look at least coronary diseases. The number of deaths was also much lower in those people who smoke lower number of cigarettes. So this is very positive information. This is the way that harm reduction can be introduced and also is good for the smokers. Of course, there is a lot of controversies which are enhanced by international organizations like WHO. This is not only the problem with the so-called heat-not-burn cigarettes, but also with, for example, COVID vaccine, which for the public health was badly needed. The COVID vaccine, which was produced with the participation of the company, it was supported by one of the tobacco companies and was made by tobacco leaves, was prohibited by WHO. So we see how this, I would say, Taliban approach to modern medicine and to treatment of many diseases is common, even in international organizations. European Respiratory Society prohibits members of any collaboration with the tobacco companies. Of course, this kind of ideology causes the very low trust for any research. Also impedes publishing research data. It's very difficult to publish the results of this data in the top evaluated journals. Also, governments are reluctant to implement tobacco harm reduction strategy in the public health. And we need to separate work on the public health strategies from ideology. This is not easy. So first of all, what are the facts? In my opinion, we have already strong facts, not only coming from the basic research. This is taken from WHO, INHEM, carcinogenic literature. Nicotine is neither initiator nor promoter of tumors and cancer. So nicotine does not cancer. And we have to first educate the population that nicotine, of course, it's cause dependence from the smoking, but it doesn't cause cancer. It has no proven toxic effect in the dose which are present in some cigarettes. Of course, very important is the temperature of combustion. We know that with lower temperature, and my colleagues talk about snus chewing, which is approved in Sweden, which has a very low level of smoking, about 5 to 7%, but a huge number of population is using snus. And in fact, indeed, we have excellent epidemiologic data. There is no cancer or vascular diseases due to the snus. So we know that clean tobacco leaves are not harmful. So in so-called heat-not-burn tobacco, we have a reduction of carcinogenic and toxic substances from 92 to 97%, for example, carcinogens in group 1, which are reduced during the heating, not burning of tobacco. And tobacco products which minimize the harmful effects are not only the heat-not-burn tobacco, so-called smokeless, refined, smokeless, unrefined, but also some cigars, e-cigarettes, and mentioned previously, snus. As I said, I'm practicing doctor. I treat many patients with COPD. So indeed, it's very difficult to encourage those patients to quit smoking. And I treat always the lungs and heart as a functionally one organ delivering oxygen to the blood. And the review of the already published manuscript shows that indeed we have some proof. For example, the paper of Ludike, switching to a heat-not-burn tobacco, and biomarkers as well as FEV1 measures, we see that improvement of all inflammation parameters like expression of ICAM molecules, improvement in FEV1 is statistically significant after switching from heat-not-burn tobacco products. Another paper from Ricardo Polosa, health outcomes in COPD smokers after 3 years follow-up, also shows a change in COPD assessment test, lower severity of symptoms, also the lower number of exacerbation in people who switch to heat-not-burn tobacco. Excellent, fantastic work published in the scientific reports belonging to Nature, effect on vascular function and myocardium. This is tremendous work. I appreciate this work very much. Not only clinical parameters like heart rate and blood pressure, but there is also important biochemical parameters, including thromboxane level, malonodialdehyde, which is very important marker of lipid peroxidation. I would like just to remind that lipid peroxidation is the chain reaction of oxidative degradation of lipids when free radicals steal electrons from the lipids and damage the cell membrane. And we see this is acute normal cigarette smoking, and this is acute heat-not-burn, and we see that the level of this biomarker, malonodialdehyde, is 2.5-fold lower. So heat-not-burn exert a less detrimental effects on vascular cardiac function and on vascular endothelium as compared to the regular. Another work published by Sharman and co-workers, also in patients with COPD, has measured many clinical parameters, including COPD assessment score, FEV1, FEC, 6 minutes walk test, HDL cholesterol, and also tobacco, heat-not-burn tobacco, improve all measured clinical and biochemical parameters, including increase in the HDL level, improvement in FEV1, FVC, a lower COPD assessment test, and lower blood pressure. This is the conclusion from this publication. So, going into the review published in Preventive Medicine by Hatsukami and Carol, I just would like to cite them that to this day, significant misinterpretation exists for toxicity associated with nicotine. In my opinion, this is first step to say that nicotine is not as harmful as is in the literature or in the beliefs, that nicotine do not cause the cancer. And this is very important. So this approach was presented by 72 experts who wrote the letter to WHO, but WHO did not follow with this letter. And also by NICE, National Institute for Excellence in Healthcare, UK, which almost 4 years ago described the use of harm reduction, a way to reduce the negative effects of smoking by using less harmful substances. Recommend for smokers who can't stop smoking, as I said at the beginning in presenting the paper from a nurse of internal medicine, this is almost 80% patients with COPD. They want to stop smoking but cannot do without nicotine. They want to quit, but they don't want to quit, but they want to less smoke. And this is why FDA permits the tobacco heating products for people to to reduce the harm, to stop smoking as a help, of course, for the smokers, not for people who do not smoke. And in Poland, the Polish Society of Civilization Medicine, with experts from various fields of medicine, including cardiologists, psychiatrists, respiratory physician, perinatology, recommended 3 years ago adding to the strategy for every smoker. This was also published in Internal and Emergency Medicine 2021-16. Health outcomes in COPD smokers using heated tobacco products. This was the comments to this paper. Patients smoking cigarettes, medical advice during every medical visit. Every medical visit. If this is ineffective, we recommend Citizen, which has excellent publication in New England Journal of Medicine, few papers showing that it has a better option as compared to nicotine replacement therapy. Just the next one, pharmacologic treatment. And if this approach is ineffective at the end, heat not burn products, tobacco heating system for harm reduction. And this will bring considerable reduction in morbidity, mortality. What we need to do, we need not only to design a good clinical trial which costs fortune, but I would recommend a plan to start a real-world effectiveness study. If we establish database, we observe our patients, and even voluntarily, we will include our observation on these patients. In majority of hospitals in Europe, we have already such a high level of informatization that it's quite easy to store this data, to retrieve this data from the hospital database. And using anonymous data, we can compare the people who smoke with those people who do not smoke and those people who switch from smoking to heat not burn tobacco products. The data already exists. A lot of this data is in Japan, and this is a very advanced public health system. So I think we will work together and we try to use smart, real world study. We are able to do this much sooner than we believe it is possible. Thank you very much for your attention. And if you have any question, I'm open to answer the question.
Thank you. Thank you, Dr. Kuna. It was an excellent presentation, and you show us the clear data that Professor Vardas asked before. Now we have data, and we know what harm reduction means. Maybe we have a question from the audience. Yes, please.
Thank you so much for your presentation. It's just something for you to comment, please. Do you think that if it would be just a question of nicotine, the therapeutic substitution would solve it and nobody else would ever smoke again? This makes sense or not for you? Can you comment, please? Thank you.
Yes. This makes sense. In this aspect, there is a letter published by New England Journal of Medicine. The study has been done in the Colorado states. They studied the dependence on the abused substances, including nicotine, alcohol, drugs, and they found that about 1/3 of the population always follow to some substances which cause dependence. So this is kind of human behavior. This is like in psychiatry, we know that more than 60%, sometimes more patients smoke cigarettes because they need nicotine. They simply need nicotine, which helps them. So we really don't know if 1/3 of our population maybe needs nicotine to function better. And now if I compare supplement with nicotine versus alcohol, which brings tremendous cost for the society, or just cocaine or heroin or some others, I think that the nicotine would be the preferred option. I'm not saying that this is healthy whatsoever, but we have to, for many years, the doctors were like a god. Whatever said the doctors, it was the truth. And I think many politicians today and many societies and WHO behave the same way. But now we have to take into account also the patient point of view. So we have to look into this problem also from the position of the patient, of the person who smokes, not the judge. You are doing something which is not good. I don't accept, our society do not accept this. This is not the freedom of choice. So we know that we have e-cigarettes. Unfortunately, cigarettes also have very high temperature to produce the nicotine, and there are some chemical reaction. And we know that we have this EVALI, inflammation, pneumonia, which may cause even the death, which was also described in the United States. So I think we need the product which are carefully studied. For example, with e-cigarettes in Poland, there is 13,000 different varieties of these cigarettes. Who is going to study this or to evaluate? Nobody. We really don't know what is in e-cigarettes. So this is why the heat-not-burn products, which are carefully studied, and there are available data, they were presented to Food and Drug Administration and to NICE. And this is why this opinion that this can be used as a strategy to fight smoking epidemic is good. So this is the position we have to look also into the feelings of our patients, not just what we want from them.
Thank you. Okay, I have another question. So we thank you again. We expect you in the next summit, Dr. Kuna. And
Thank you.
we have now a lunch break. Right? It's time. Thank you.
Okay, thank you very much for the invitation. Have a good lunch. Goodbye.